So good morning, ladies and gentlemen. I am very privileged to welcome you all here to the new Orthopedic Grand Rounds format. We're very honored to have as our first guest speaker Dr. Samir Mehta, assistant professor from the University of Pennsylvania. The occasion that we're all here today is a very sad one. There was a tragedy, as we all know, that struck Haiti a short while ago, and our profession as orthopedic surgeons was very much called into action as there were so many injured and crippled people in Haiti. Dr. Samir Mehta is a very welcome guest and a repeat visitor here. He's a graduate of Temple University in 2000, and he did a fellowship with us after concluding his residency at the University of Pennsylvania from, I think, 2006 to 2007. He's had a couple of other distinguished accomplishments in his young career. He was the AOS Healthcare Policy Fellow in Washington, D.C., and he was a John Border AO Traveling Fellow, which he spent in Europe. So we're very pleased to have him back here. He's currently an assistant professor at the University of Pennsylvania, as I said. And I'll also introduce my partner and colleague, Jim Krieg, here. He's an associate professor in traumatology with us. The two of them have somewhat different perspectives of the events in Haiti, and I thought that it would be a good kickoff for us to reflect upon our profession as orthopedic surgeons, but also reflect upon healthcare delivery under difficult circumstances with their different expertises. Without further ado, I'll ask Jim Krieg to take the lead.
Thanks, Jens. You know, one of the most surprising things when I got back from Haiti was the level of interest that people in the community have had in sort of what we saw and what we experienced down there. So Jens thought this would be a good opportunity for us to present what is probably very different experiences. I know a number of different people went in different groups and saw it through different eyes and experienced it very differently. And I think we'd like to give you a little bit of a flavor of that this morning in the brief time that we have and go over just a little bit of what we saw in Haiti. So just as background, so everybody understands on the same page, Haiti is a little bit unusual. It's right smack in the center of the Caribbean. And obviously, if you look at this list, it sticks out from all the others because it's probably the only one that doesn't have a resort that you might have heard of or would want to visit. It's very different than the rest of the Caribbean. Politically, it's been very important over the years, both to us and other countries, because of its proximity to the U.S. It's less than a 2-hour flight from Miami, and obviously here on the map you see it's a stone's throw from Cuba. So over the years, it's had a very important political history in our relationship. Just to kind of recap Haiti's history, obviously everybody I think remembers Columbus landed there in 1492. Within 30 years, the native Indians that had populated the area were essentially decimated, almost completely wiped out due to the disease that was brought in as well as the slavery. What replaced it was a Creole mixture of the native blood, the African slaves that were brought in, and the European colonists. By the early 17th century, the French had arrived, and they arrived as pirates and tobacco farmers. And by the late 17th century, Spain had essentially given France the western one-third of the island. And so they called the colony Saint-Domingue. And really what evolved there was primarily sugar plantations, which were very, very profitable back then. It became very quickly the wealthiest French colony. Unfortunately, that came at a price, and the price was in large part deforestation and, as I said, the influx of slaves replacing the natives that had already been there. By the 1790s, less than 100 years after the French took ownership of the colony, there was a big slave rebellion. And that essentially is how Haiti was born as a country. And there were a few very important figures that to the Haitians are as important as people as George Washington are to us. And there was the one former slave that was a military commander who started the whole thing, Toussaint Louverture, who unfortunately was arrested by Napoleon's brother-in-law, who was sent to Haiti to try and squelch this early rebellion. The French paid quite a price in giving up Haiti. They lost 50,000 men to the rebellion. Louverture died in a French prison, and his work was taken over by Dessalines. So by 1804, Haiti was an independent country, which when you put it in perspective is really amazing. It was the only nation in the world born of slave revolt. The name was taken from the native Indian language to mean land of high mountains. Again, I think that's a bit of foreshadowing as to some of what played out with this earthquake. It was the first independent nation in Latin America, the second in the Western Hemisphere behind the United States, and the first black-led republic in the world. So politically, it has a very unusual history, and again, that's perhaps one reason why it really stands out in the Caribbean. The U.S. became very intimately involved in Haiti early on. Shortly after World War I, as a bit of an extension of the Monroe Doctrine, we felt this sort of obligation, if you will, to go to places like Haiti and try and provide infrastructure. So the U.S. was really instrumental in trying to provide some of the, perhaps the latest incremental increase in the infrastructure in Haiti. Unfortunately, the native politics sort of took over, and Papa Doc was elected in 1957. Shortly thereafter, declared himself president for life. I think that's that famous saying that most people have tagged to Papa Doc. He was president for life, and upon his death, his 19-year-old son, Baby Doc, took over. They were not the fairest of rulers, I think would be putting it kindly. Baby Doc was a bit of a world-renowned playboy who kind of pillaged the national treasury. They're still fighting over some of that money in Switzerland as we speak. He had some early problems that ended his tenure relatively swiftly. There was a swine flu epidemic, which required that they kill most of the pigs in the country, which was a large part of their farming sustenance. And of course, the AIDS epidemic hit them pretty hard. So Baby Doc was tossed out, and they went through a lot of different governmental regimes. Until 2000, there was a lot of hope in Aristide, a former priest who was democratically elected. But again, unfortunately, he was thrown out under rather tumultuous times. So the UN came in to try and provide some stability in 2004. But if you look in the bottom part of the screen now, you see what the UN headquarters now looks like, which is not very conducive to being very helpful. How poor is Haiti? Well, to put it in perspective, 50% of the population had no access to clean water before the earthquake. 50% of the adults had the equivalent of a middle school education. The GNP is a very small fraction of what it is of the Dominican Republic, which shares the same island. 60% unemployment before the earthquake. And really, you're talking about people who live on very small plots of land and farm and trade in that sort of regard. So it's by far the poorest country in the Caribbean. And I think that for everybody, what's been so striking about this is that the disaster was as much social as it was geologic. So just to put it again in sort of geologic perspective, we had a very similar magnitude earthquake in 1989 in San Francisco when the Bay Bridge partially collapsed, and we had 66 dead and 3,800 injured. Haiti obviously had a very, very different experience. Their construction was very different, and I think the results have been borne out. Over 200 to 250,000 dead, 300,000 or more injured, and at least 1 million homeless. So quite a dramatic difference from a very similar geologic event. So that's just sort of background. How did I end up there? Well, that's another interesting story. This, for me, all started after 9/11. When I saw what had happened, I tried to figure out how can I respond in the event of a disaster. And what I found was that the U.S. government actually has a pretty comprehensive system that anybody can volunteer in. So shortly after 9/11, I joined an organization in Oregon called the Disaster Medical Assistance Team, or DMAT. When I moved to Seattle, shortly after that, in 2007, I switched to another organization called IMCERT West. Because it's the U.S. government, all of these acronyms have to be decoded. So to give you a little bit of a background, all of the health efforts in the United States, the federal government, are run through the Department of Health and Human Services. Obviously in the news quite a bit these days. HHS oversees a lot of different subgroups, and one of them is called the NDMS, or the National Disaster Medical System. The NDMS is a number of organizations, one of which are these DMATs, which are state-based, locally organized volunteer teams. They are federally controlled and federally organized, and it's somewhat analogous to the National Guard. So every state has a DMAT, some have several. That's sort of a first response aid station, perhaps general hospital, ER-type response team. There are 3 teams that are a bit more comprehensive, and they're called IMCERTs, or International Medical Surgical Response Teams. The 3 are based in Boston, Seattle, and Miami. Essentially, well, we'll get into a little bit about the IMCERT in just a second, but the IMCERT is, again, sort of a surgical response, a little bit more than a DMAT would be. When it comes to U.S. aid overseas, all of our humanitarian efforts in other countries are typically run through USAID, which is the United States Agency for International Development. It's obviously a big budget organization because it's, like I said, essentially all of our aid to third world countries and others. So when it comes to an international disaster, USAID oversees all these other organizations that the U.S. provides aid through, one of which, of course, is the DoD, or the Defense Department. So how does the IMCERT work? Well, essentially the IMCERT, if you can imagine, is a mobile hospital that can do surgery, can do medical care. It functions essentially like a MASH hospital would, if you could imagine the military scenario. It's multidisciplinary. There are quite a number of people that respond, from firefighters to paramedics, EMTs, nurse practitioners, nurses, ER docs, all across the board. It's essentially a thin slice of what you would see at a trauma center, for example. And most of the people that make up the IMCERT team here in Seattle are probably folks you run into every day at work. And, you know, again, my kind of disclaimer is I'm just a very small part of a very large organization that, again, is people that most of you work with every day and really do quite a bit of volunteer work for. The equipment for this mobile hospital is kept on pallets at a warehouse nearby. And the theory is that at the moment of a notice of a catastrophe, these pallets are to be driven on military-type vehicles onto military aircraft along with the personnel and can be deployed anywhere in the world within 48 hours. So that's kind of how the insert's supposed to work. Disaster response is kind of interesting, and I like this African proverb because we all had very different experiences through very different organizations, and it reminds me of this: if you want to go quickly, go alone, and if you want to go far, go together, because the size of the organization really makes a difference when it comes to how you respond. And of course, there's this little addendum which Al Gore added, which is we need to go very far very quickly sometimes. So it becomes a challenge. There were quite a number of private groups that went. Again, we've heard several members of the audience went with private groups here. This is just a small group from Colorado Springs of surgeons that just packed up a private plane and left. And for those of you that have been in Seattle for a while, you may recognize Alan Bach there, who's a hand surgeon who was in Seattle for quite a number of years. There was a famous team from New York who's written about this in the Wall Street Journal and others, from the Hospital for Special Surgery. They were friends of the Clintons. They were funded by a wealthy businessman who sent them down on their jet. And again, just another example of one of the many private groups that went down. Our team, on the other hand, being the federal government, was quite large. What do you need if you want to respond to a disaster? Well, you need a lot. First of all, you need permission. You need to think about things like passports and visas, medical licenses, and malpractice. We are covered under the Federal Tort Reform Act, which means that any acts we commit are considered on behalf of the federal government, so we don't get individually sued. Not that, excuse me, that it matters in Haiti, but it's just as background for other disaster response. Transportation was a big, big concern in Haiti. And again, it's not just getting there, but getting around and getting home and getting your supplies. You have to watch out for your own health care. This was people kept saying it's an austere environment, but the reality was pretty stark when you saw it. I think most people know by now that there's quite an AIDS epidemic throughout Haiti, and as a result, there's a lot of tuberculosis. We were on malaria prophylaxis. We had these masks, these N95 masks to try and prevent the spread of tuberculosis. There's a whole host of things that you as a provider need to watch out for just for your own health care. You need water. You can't count on any running water in a country like Haiti, even under the best of circumstances. So we brought tons and tons, literally tons of water. Food, we brought MREs, which are what the military eat. Shelter, we brought both tents for sleeping in as well as these little cot shelters, and we had the 82nd Airborne. And I can't say enough good things about the 82nd Airborne. They were phenomenal. Not only did they provide protection, but they were amazing at crowd control, and that's how the U.S. government disperses aid in times of crisis. So a lot of people criticize the U.S. for sending so many Army troops as if it were some type of occupation, but that's literally how we distribute food and water. We use our Army, and they were amazing. We needed our own power, so we brought generators. We had a whole lot of stuff, and I think that's a gross understatement. I'll give you a sense of the timeline. The earthquake occurred on Tuesday the 12th at about 1:43 Pacific time. And again, I think everybody now knows the magnitude and location. By 5:20 that afternoon, I got a page that they were looking for available roster. By midnight, or shortly thereafter, we had an official roster. Within less than 11 hours of the earthquake, we had an official roster to go. By 8 a.m., I picked up my passport at the Burn ICU, my official government passport. And by noon that day, less than 24 hours after the incident, we were officially activated. So I left that night on a red-eye for Atlanta. And unfortunately, in this instance, there were so many people going from the government that we went on charter aircraft. So by Friday, we left Atlanta. We flew on charter airplanes into Port-au-Prince. And what we saw when we landed was not what I think what anybody would expect. It was an airport that had been essentially condemned. The glass was all broken out, and there were cracks in the walls, and the airport terminal was unusable. The number of aircraft from other countries was beyond description. I mean, you name a country and we saw an airplane from it, all shapes and sizes. It was just an overwhelming scene for an airport that had one airstrip. Traffic control was the guy on the ATV. He went from a Honda 50 mini trail mini bike to an ATV by the end of the time I was there, and he would go out and greet the planes and kind of point at them where to park. In the midst of all this, in the infield around the runways, was this constant coming and going of survivor aircraft there, of search and rescue teams, and of supply chains for the U.S. government as well. This is essentially what functioned as a terminal on the tarmac, both for supplies and people. And there were countries from everywhere in the world that used it as their base of operations, just to set up their tents for their search and rescue. We had the privilege of sleeping on the ground at the embassy when we first got there because that was our base of operations until deployed out into the city. And while there, I have to say I was really impressed, probably mostly impressed, my whole experience with the USAR teams. That's Urban Search and Rescue. These are the guys with the search dogs. They were really something, and they came from all over the U.S., and again, were based at the embassy. There's another guy that I met at the embassy who was a private citizen. I think he deserves special mention. His name is Henri Ford, and he happens to be the surgeon-in-chief at LA Children's, but he's a Haitian who grew up in the neighborhood where we were serving. He was educated at Princeton and Harvard and then went to LA, but upon hearing about the earthquake in his old neighborhood, flew back and actually joined our team as sort of an unofficial member. This is the line trying to enter the U.S. Embassy of people that were Haitians that had some American connection. Many of them were citizens trying to get out, and that line never got smaller the whole time I was there. This is us actually heading out into the field from the embassy to where we set up our hospital. We happened to choose a site that was very interesting. I learned about it when I got back to the U.S. It's called GESCIO, and it's an acronym for the Center for Kaposi Sarcoma and Immunodeficiency Research. It was set up by this gentleman you see on the bottom. His name is Jean Pepe, and he was trained at Cornell. He's another Haitian. It literally is the first AIDS clinic in the world. It was set up in 1982, and it was very, very well organized, and it was really decimated by the earthquake, although his buildings were still standing, sort of. This is where the entrance to his compound, where we came through, in the middle of one of the poorer communities in Port-au-Prince. The site was chosen because it was something that the 82nd Airborne felt that they could secure from the crowd. And so there was a tent city right next door, but they tried to keep it separate from us just for logistics so that we wouldn't be overwhelmed by the crowd. But this was the folks living outside our front door. And so we were within a courtyard that was in a square compound of single-story buildings. And that's where we basically set up this tent hospital. We used some of the buildings. The porticos were usable for shelter. Much of it wasn't usable just due to the damage. A few of the rooms, again, people were sleeping in, although you couldn't get me inside them. The aftershocks were actually pretty impressive at times. So we set up our tent hospital, and just to give you a little bit of a perspective, these are modular tents, again, much like the military uses. On your right, you see the preoperative area. The center is the OR, and then on the left, there's another one connected. That would be the post-op area. That's our OR staff actually sterilizing equipment. Instead of an autoclave, we use Sidex, which is a chemical sterilization process, and that's the scrub sink. By the time we left, we had a filter that was set up to a spring that had kind of evolved from a broken well. So we did have some running water at the time we left. Before that, we were using bottles at the scrub sink. This is our OR, and to put it in, again, perspective, this was set up within 12 hours of us landing on the site. So this is a fully functional operating room within 12 hours of hitting a courtyard. Very well stocked. All of this comes prepackaged in easy to open boxes and really can be just opened up right on the spot. This was our anesthesia machine, again run on the generator, very effective. This was our pharmacy, inpatient and outpatient. All of this just unfolds and it's ready to go. This is the entrance to the compound with a few makeshift braces. And this was our triage area. At times it was obviously much fuller than this, but this was sort of right outside that entrance where people would be either kept overnight waiting to see us or triaged when they showed up. Very typical scene in our emergency room tent, not a lot of cots, and then a lot of sort of walking wounded or people that were brought in by friends or relatives. Again, our discharge coordinators, we would see people as quickly as we could and get them out without much understanding of follow-up. We hired locals for interpreters because none of us obviously knew Creole. Very typical injury, a crush injury with some degloving, which presented a week and a half out. Underneath that, unfortunately, there were fractures. So a lot of these cases, just due to the equipment that we had, we were debriding and then placing them in casts. Some people showed up with x-rays. I don't know where they got them. I don't know how they got them, but people would just show up with printout of an x-ray and then just be delivered. This is that patient. This is Chris Bourne on the right, who's the chief of orthopedic trauma surgery at Brown, and myself putting external fixators on that patient. No power equipment, no fluoro. These are hand-driven external fixator sets that are prepackaged for the U.S. military. And again, operating by headlight because, again, we didn't have any OR lights. So this is Chris, again, using our makeshift x-ray board, aka the sun. No power tools. This is an acute shortening of an open tibial fracture so that we could close the traumatic wound. We were doing it with a giggly saw, and then we placed an external fixator. The government spent a lot of money on the EMR. To be honest, this was the real medical record. We tried to write on the patients, but realized right away that the dark Sharpies wouldn't work on dark skin. So we were writing on the dressings and on the external fixators, whatever we could. We provided every patient that had an X-fix with a wrench in the hopes that somebody could figure out how to get it off someday. We would try and describe what we saw and put it over the cast. We saw quite a number of crush injuries, digits being amputated. We learned not to operate with gowns on because it was too hot. We provided a lot of primary care medicine for the folks that were there in the village. This is a baby being born in the midst of all this. And we provided a lot of evacuation to the comfort. I know a lot of people have heard about the hospital ship that showed up. We were a major staging ground to get people to the comfort because we were part of the government supply chain. A lot of kids would show up on litters, 2 or 3 to a litter, many of them mildly injured or even not injured because nobody could find parents or they knew they were orphaned. This is an unfortunate example of the difference between time and location in a relatively severe but treatable injury in the U.S. This is an open tibial crush injury in a 3-year-old that came to us 10 days out. Grossly infected, horrible damage to the knee, to the growth plate, and really only one treatment could be rendered, and that was an above-knee amputation. So, again, pretty dramatic differences. I think everywhere you went, I think everybody, again, has heard of all the scenes of destruction and how much help people needed, how much infrastructure has been lost. This is a school. This is a very wealthy neighborhood in an area called Pétionville. This is obviously their governmental head, the equivalent of our White House. This is their main church. It would be the equivalent of, say, St. Patrick's Cathedral in New York City collapsing. And again, I think everybody has heard about the tent cities that have sprung up. Within 2 weeks, what was impressive to me was how a country that could be so devastated in terms of infrastructure could be recreating what to them must seem like a new normal, I guess, for lack of a better description. There's already some commerce being undertaken on the side of the road, which I'm told is very similar to their normal. This is a guy getting a haircut with stereo hooked up to a battery in the tent city. This is cold beer in the tent city at the local bar. This is actually a brothel in the tent city with the price listed right on the sign. This is a butcher shop, again, in the little tent village. That's a goat being slaughtered for sale. So a lot of things have sort of come full circle, I think, for the Haitians, but clearly the effort continues. And looking back on it, what did we do as a small group? Well, I think it's pretty impressive that we set up a brand new healthcare facility from a courtyard. We provided care within the first week for over 200 patients, but again, we were only providing care for the several days of that. I'm talking within a week of the earthquake. We had a system where new teams were brought in every 2 weeks to replace us and replenish. We were able to decompress the local hospitals, and we did some triage for the comfort, and we were certainly a staging area for the relief that the U.S. Army provides. So that's a little bit of background about what I did, and hopefully a little bit of a quick flavor. So without further ado, I'd like to turn it over to Samir, who again, as you heard, is the Chief of Orthopedic Trauma at Penn, who went with a very different organization that he's going to tell you about.
I want to start off by thanking Dr. Chapman and the faculty here for inviting me. It's really an honor to be back at the University of Washington in Harborview, particularly being with mentors and friends. So I do appreciate that very much. I think you're going to see that my experience in Haiti, or our experience in Haiti with our team was a little different than what Jim encountered as he was deployed early. Talk a little bit very briefly about Haiti. You can see this is a map of Haiti. We're going to focus in this region. You see Port-au-Prince here. As you zoom in on it, we were in Cange. Cange is about 45 kilometers northeast of Port-au-Prince in an area that was completely unaffected by the earthquake. So there was no structural damage to the facilities. The hospital that was there was completely intact. And for the most part, it was a fully functional hospital that we were at. It's important to note that this body of water here is the water supply to Cange, and it's part of the reason the hospital was set up in Cange, because it was one of the first places that had running water. So we went through the University of Pennsylvania and an organization called Partners in Health. I'll be honest, I knew nothing about Partners in Health until someone told me that was the organization that we were going with or going through. It's a non-governmental or NGO-based organization out of Boston. It was established in 1987 by Paul Farmer and Ophelia Dahl. Paul Farmer is a physician. Ophelia Dahl is the daughter of Raymond Dahl, who wrote Willy Wonka and the Chocolate Factory, and so there's some prestige, I guess, associated with that. But their initial efforts were in Cange, in Haiti, and that was because Paul would actually go to Haiti in his time off in medical school and basically go around the country delivering medical care as a medical student. And if you're interested in his efforts, there's a book called Mountains Beyond Mountains, which is a biography of Paul Farmer and how he established not just the NGO in Haiti, but also how he's established clinics worldwide, including Rwanda, Botswana, and other third world countries, delivering predominantly medical care to these nations, mostly HIV and TB related. Haiti's been called a republic of NGOs, and we kind of heard a little bit why through Jim's presentation about the governmental infrastructure or lack thereof. The estimates are somewhere between 300 and 10,000 NGOs in Haiti. And one of the downsides is that there's a lot of resources that are directed directly towards the NGOs as opposed to being directed towards the country itself. And so these NGOs are really playing a very prominent role even before the earthquake in the overall deployment of healthcare, resources, agriculture in a country like Haiti. They're starting to differentiate the NGOs in Haiti as some of them being Haitian-based, and one of them is Zanma La Santé, which is Friendship in Health, which is actually the sister organization of Partners in Health. So while we went with Partners in Health, we were working through Zanma La Santé, which is Friendship in Health, which is a Haitian-based NGO. And so they're starting to try and differentiate the NGOs in Haiti, those being Haitian-based and those being foreign-based. So there are 9 of us that went down from the University of Pennsylvania. We took 2 anesthesiologists, myself, an orthopedic chief resident who's doing a trauma fellowship, 2 OR technicians, 2 critical care nurses, and 1 general trauma surgeon. My overview is going to be a little different than Jim's. I really want to paint a perspective of what we did for the 2 weeks that we were there. So I'm basically going to give you a timeline of how we did what we did and why we did what we did. And there'll be a bit of a social commentary as well as some orthopedic commentary. So we were deployed on January 25th, almost 2 full weeks after the earthquake. And we went down in a fairly strategic fashion. We contacted the Dartmouth team that had been deployed to Hinch. We contacted, actually I talked to Jim a few times in Haiti, and his biggest advice to me was bring some unscented baby wipes. So I did take down a pack of those, and they were very handy, actually. We left, which was somewhat ironic, on a plane that was donated by the folks who are the sole suppliers of chicken to McDonald's. And the irony was that this was a very, very nice plane, very fancy, lots of nice food and amenities, and it was just completely contrary to what we were about to go into. We were greeted by the U.S. military, and I can't say enough good things about the U.S. military. They were nothing but phenomenal upon our landing. This was what you see here is air traffic control, a tent in the dark. This is the airport. You can't really see it because it was completely pitch black. Planes were taking off and landing on a single airstrip, as Jim described. And it was a bit nerve-wracking when you get off the plane and this is what you see. It was the first time I'd been on a plane and not had a ticket to come home, and no idea when we were coming home, to be honest. Everything was covered in dust. We had brought about 1,200 pounds of equipment. We packed it up on 2 SUVs and waited there for several hours until security clearance could get us out of the airport. We left the airport. The airport was very secure. The minute we left the airport, for those of you who've seen Mad Max, the Mel Gibson movie, it was very much like that. Burning fires, people wandering in the streets, people just waiting outside the airport as that territory wasn't very secure. We were taken to the Aristide Foundation, which was set up by Partners in Health as their home base. We slept on tents. Just to give you an idea of the infrastructural issues in Haiti, for those of you who go camping, you put stakes into the ground. These stakes are pounded into the cement, so you can get the idea of the quality of cement work that was there, because you can pound these aluminum stakes into the cement ground. We spent one night in Port-au-Prince. Still actually hadn't seen Port-au-Prince and the disaster that had happened. Everything was in the cover of darkness. We got up the next morning around 5 a.m., loaded up a bus with all of our equipment, and headed up through the outskirts of Port-au-Prince towards Cange. And as we're driving through, I had mentioned to my driver, is this post-earthquake Haiti? And his response is, this is actually Haiti, just the way it is. And it was a little discouraging. But I would tell you that it seemed like business as usual. Traffic was bustling. The tap-taps, their versions of taxis, were out running. People were in them. Commerce was happening. It didn't really seem all that bad, to be honest. But my perspective would change very quickly. I actually didn't feel very far from home. This is a truck that drove by us while we were on our way to Cange. So as we're heading up, Port-au-Prince is in the background here. Cange is in the central plateau region of Haiti. It's actually in a non-deforested region. Most of Haiti has been deforested, but this was actually a fairly lush. This is that lake that I pointed out to you on the map. This is where the water comes from, and it was actually a very beautiful part of the country. We were greeted by the entrance to this hospital complex centered around a church. This is one of their ambulances that they had there, and this is the rest of their ambulances that they had there. There were multiple dogs that just roamed free on campus, and I'm not sure what they fed on, but I have my suspicions. Blood bank, hematology, lab work. This is all of their blood bank. A college refrigerator, and I think there were about 14 units of blood there. Changing dressings on the floor. This is a woman with a guillotine amputation, and this is our first day there. We're getting a tour of the facility. She's screaming in pain. It sounded like she was giving birth potentially. No narcotics being given to her as they were changing her dressings. This is one of the general surgery faculty members there, or attending physician, changing these dressings. He had not done an amputation during his career. This is what the operating room looked like there. We actually had legitimate operating rooms. You can see an anesthesia machine. Light boxes were just hanging your films in front of a fluorescent light. You can see the light handles that we had. You can see the level of sterility. You had enough drapes to drape out what you needed to drape out, and everything else was sort of open. We had Bovie machines. I mean, it really was a fully functioning OR. This is the outskirts of the hospital. Again, a community that's bustling and a lot going on. This is the pediatric ward, 2 floors. This is the church. I said we were centered around a church. The church was converted to a hospital ward before we got there. It had about 60 patients or so. You can see that the patients are there just on the floor. Maybe if they're lucky, they had a mattress, and they were with their families. I was very impressed by the sheer number of patients and their families. Their families were their nursing staff, their families were their caregivers, their families were by their sides 24 hours a day, 7 days a week, and I can tell you that I was very impressed with the family unit. So our first day assessment after our tour was that we were at a 130-bed hospital. We had 211 patients, and 57 interventions were identified upon our first set of rounds that we were there. We were following a team that was from Ireland and a team that was from Santa Monica who had done some stellar work. And so we had about 16 open fractures, 16 closed fractures, some revision amputations to do, some primary amputations to do, and multiple soft tissue injuries to manage. And that was prior to us really having a handle on what exactly was going on. This is the view from Conge, from the hospital, and this is partly that title that you saw in that book about Paul Farmer, Mountains Beyond Mountains. So our third day, we kind of got ready. We actually had a place to sleep. There was actually no ceiling here, so it was a little weird. We had a door, but no ceiling. Mattresses would get wet when it would rain, but we had mosquito netting, and it was some place to sleep, and I was considering what I'd heard and seen in Port-au-Prince. I was very appreciative. We also had running water. Running water started at about 7:30. We typically started rounds on our patients at about 6:30 in the morning, so we rarely showered in the morning. We were on the Q3 day shower plan, which is where the baby wipes came in very handy. This is our scrub sink. It was also where they disposed of blood. It's also where they disposed of urine. The irony of this is you're washing your hands in water that you won't drink. So it was a little, these are the kind of things that you kind of take a step back and be like, is this really happening? This sink is actually not connected to a pipe, which becomes important in a little bit. This is part of our central supply. It's just right outside the operating room, boxes of equipment stacked up. You kind of went through it the day before. You planned your OR day for the next day, and you kind of just picked what you needed to pick. And if you needed something, someone would just run out in front and dig through the boxes to find stuff. It wasn't very well organized. Remember, this isn't a surgical hospital. It's a medical hospital, predominantly TB and HIV. So they're not used to doing this kind of surgical volume. One of our Cuban CRNAs, excellent, absolutely excellent. I can tell you the delivery of anesthesia care was nothing less than phenomenal. Turnover times were 10 minutes or less, which you can say what happens to clean the OR, but that's a different story. At the University of Pennsylvania, we have Navicare. I think you have something similar here with your digital OR scheduling system. This is our version of Navicare. We would list our schedule and then hand copy it and post it in all the clinic wards so everyone knew what the schedule was for each upcoming day. The first day we had the opportunity to do 13 cases. This is the surgery ward. People just lined up next to each other. Open wounds next to infected wounds, next to closed wounds, next to TB patients, next to gallbladder patients, next to open fractures, next to closed fractures. You get the idea. This is the ER. I'm standing at the door of the ER. It was a one-bed emergency room. We were called out of rounds in the morning due to someone being an extremist in the emergency room, so we ran down to the emergency room. I'm taking this picture, really not very helpful, but I'm just taking this picture of what's going on in the emergency room. And this is, I just want to take a moment to comment. This is one of the medicine pediatric residents from the Harvard program. They have a global equity health residency program that's in combination with Partners in Health, and they send residents all over the world. And he basically ran the entire church ward. He ran a ward of 70 people. That's predominantly surgical. He was a medical resident. And let me tell you, he did a fantastic job. All of the volunteers from Partners in Health sustained that hospital to an unbelievable degree. The medical student who ran the service ran a 140 patient service for us, kept tabs on everybody, kept an active list going, rounded with us in the morning, rounded at night with us. Absolutely unbelievable. This is the commotion we caused when we ran down to the emergency room. These are people who were either waiting for care, they would be lined up in the morning, or they were out from the outside community. They saw the American doctors running to the emergency room and got very worried. Again, there's a sense of family in the country. Posterior wall fracture dislocation, treated here with ORIF, Kocher-Langenbach approach, prone, as many of you have seen at Harborview. This is what we had to do. No fluoro in the operating rooms. We had one x-ray machine in the hospital, and so we did have power and drills, and so we were able to put on an external fixator with power, but did it blind. Have no idea what this looks like and won't know for several days. Subtrochanteric femur fracture, intramedullary nail, no-brainer, maybe a blade plated if you're so inclined. This is what she got. And the dictum that we were sort of inherited or were told was, one, don't criticize, and two, if it's closed, leave it closed, and if it's open, leave it open. We couldn't find external fixation wrenches our first day. We found this. This is my orthopedic resident unttightening one of the X-fixes. It was what it was. This is my favorite picture because there's something on this picture, and I'll throw it out to the audience if they see something here. The fly swatter, yeah, that's great, isn't it? When you see that in your operating room, that was a major issue. We had flies in the operating room. So when you had an open wound that you were skin grafting or closing, and there was a fly there, after you've already irrigated it out, it was a bit of an issue. And so the other thing, you have one back table the entire day, so you had to plan accordingly. You didn't get to clear your back table and put a new back table up. You had one drill set, so if you used a chuck, you were done for that case or that day with that chuck. And so you really had to plan your cases appropriately, line them up appropriately, and if things got rearranged, it was really detrimental to the day. Kinds of wounds that we would see, this is a several-week-old fracture, open wound, really very little capabilities to do a flap, or didn't really want to do a flap when there's a fly sitting on it as you're about to put a skin graft on it. Soft tissue management was very difficult. This is his defect, a 4-centimeter defect in his tibia. We thought we'd be heroes and do an iliac crest tricortical bone graft, which we did that day. Actually turned out okay, and I'll show you some pictures of that. It wasn't just orthopedic. This is a patient's gallbladder being taken out. She had a hemoglobin of 4 and was HIV positive and later died about 3 days later. Dead arm, ended up getting a above the elbow amputation. Subtrochanteric femur fracture in a 12-year-old, needed an open reduction internal fixation. Patients were stoic, they were phenomenal, they were cooperative, they kept their x-rays by their bedside, ready for you on rounds, soiled casts that we had to change, some soft tissue wounds. Reporters from around the world would stop by, and I was a bit frustrated by this, but at the end of the day, you realize that they were drawing attention to a problem. My biggest fear is what happens when the cameras go off and the lights go down, who's going to talk about it then? And so to some degree, I think it's important that the media appropriately give this attention so that people don't forget. This is our first OR day and the end of the OR day, if you will, with everything crossed off. We did get to everything, despite the length of the day. We did things in there that we probably wouldn't do here in the States. Proximal humerus fracture treated with a tibial nail because we didn't have humeral nails, and so it works, and his x-ray looks reasonable, and his neurologic function is good, and you can see the next patient's ready to show us his x-rays. Again, very appreciative. There's no place to send them, so even though he's quote-unquote done, he has no home to go to. So they would just stay at the hospital. They might stay outside the hospital or outside the actual ward complex in a tent or on the ground, but they have really nowhere to go. Typical soft tissue wounds. Patients were very stoic. They were very appreciative. It was a good experience. This is an open tibia that came in fresh from the earthquake. He had wandered up from Port-au-Prince because he realized that he was so far back in the queue in Port-au-Prince because they were so backed up. And this is what his wound looked like. Necrotic bone, infected, purulent. All we could do was put a frame on it. Couldn't even really reduce it very well other than cutting the bone short. This is a young lady who had her amputation done, guillotine amputation in Port-au-Prince about 2 or 3 days after the original earthquake. Unfortunately, she also realized she was in the queue and so made her way up via family who had access to a motor vehicle. And this is what her arm looked like when she showed up. So we took her back, debrided her, and she ended up getting a 4-quarter down the road. This is that posterior wall fracture dislocation from 2 or 3 days prior. So you can see this is the time lag we have between knowing doing what we did and knowing what we did. And it was a bit frustrating because you wanted to act on things but didn't know how or what to do. And so it's reduced. It's fine. And you can see family members interested back here in what's going on. And again, the sunlight being a wonderful X-ray box. This is that iliac crest bone graft in that patient that we did. We were able to get his wound primarily closed, and he didn't pus out at least the 2 weeks that we were there. We had the ability to do teleradiology or telemedicine. I had contacts back at Children's Hospital, and so I would send them pictures of some of the pediatric patients we would see and get their opinion on how to manage these, and I ended up wedging both those casts and those fracture patients. An IV pole. Again, it's a 120-bed hospital that's running a 200-bed capacity, they don't have resources to take care of their 120 patients they had, let alone the 200, so you may do with what you had. So that was our IV pole for this patient with a pelvic ring injury. Jim showed a great slide of the central supply area being very well organized. We had tons of supplies. We just didn't know what they were or where they were. Every team that came down would bring a bunch of stuff with them, and it would be just thrown into this box. And so somewhere there in there was a rongeur, somewhere in there was a bone biter, somewhere in there was giggly saws, somewhere in there was a mesher. We just didn't know where things were. Orthopedic resident from Port-au-Prince, 4th year, very knowledgeable, skill set that was rather limited because of what they see in Haiti and what they're able to do, but he had nowhere to go. He heard that we were in Cange, so he came up there. His residency program doesn't exist anymore. This four-pronged extension cord becomes very important in a little bit. You saw this injury before, but this is a very typical soft tissue injury in the forefoot. Things fall down, scrape off the top of the foot, eventually got skin grafted. We didn't have a mesher at first, so we just meshed it ourselves. This is autoclave. This is the guy who processes the autoclave. Okay. This is a young lady who was involved. She was actually reduced very well. Aftershocks came. She got scared, ran out of the ward, and ended up displacing her tibial shaft fracture. So she ended up having, and this is her open wound that she had sustained and reopened after she walked on it. So we actually brought a little bit of Harborview to Cange and ended up doing Donati Agar's on her to get her to close. And she closed up very nicely. I'll show you what she looked like in a little bit. This is a young man, had a head injury at the time of the earthquake, was bounced around hospital to hospital. Eventually showed up to our hospital, needed a bolt. Unfortunately, we had no ventilators at our hospital, so we tried to transfer him to the naval ship. Unfortunately, his GCS was 3, and the naval ship had, rightfully so, was allocating resources appropriately. We tried to get him to another hospital that had a neurosurgeon and a ventilator in the local Haitian area. Unfortunately, they refused, and so he died about 2 hours later. That same night, this is a patient we were consulted on. Again, it wasn't all earthquake related. A mass on his calcaneus. This is his inguinal lymph node, and this is his X-ray. So it was a bad day. This is that medical student I told you about running the 120 to 130 person service, and again, exceptionally organized and really well done. Rounds in the morning. This is one of the wards. These are some of the Haitian doctors that we worked with in Cange, and you can just see patients lined up. It was just patient after patient. Patient transport, gurneys. These guys were machines. They would take these patients all over this hill complex and would get them to radiology and into the OR in a timely fashion. I can't tell you how collectively how organized and how well run it was. Greater tuberosity fracture with a humeral head dislocation. Again, one of our other patients needed a soft tissue skin graft. You can see the injury that he sustained. This is that subtroch from 3 or 4 days before. We finally got x-rays. This is what it looked like. It's I don't know how it's going to do. I don't know how it did. I have no idea. I have no follow-up on these patients. I don't know if this patient pussed out. I don't know if this patient's healed. I have no idea who's going to take that X-Fix off. After a long night, you can see the Prestige on the desk. Prestige is a local Haitian beer. We got fed. We got fed actually very well. 2 meals a day, rice and some sort of bean mix, and then a mystery meat of some sort, and plantains. And we had water and amenities that you would expect in the States. And so it was more than gratifying. This is what we slept near and around. We also took the same approach that Dr. Krieg's group did, just started writing on dressings. It got to the point where it was too confusing. They were paper charts, they were in French. I don't speak a lick of French. And so we just started to write on dressings. Delta 2-1, change February 1st, because that's when we wanted to change our dressing. Yeah, it's a tibial shaft fracture, would do great with a lag screw, might even do great with an intramedullary nail. Unfortunately, without fluoroscopy and without the adequate resources, she was being managed in an external fixator with multiple washouts. She actually needed a flap, and eventually we transferred her to Port-au-Prince, where I think she did get a flap. This is where the patients would line up at night for the emergency room. It was like lining up for tickets to a rock concert. They would just line up and wait for us in the morning or wait for somebody in the morning. ORs would flood. Remember I told you that sink didn't have a, wasn't connected to a pipe, and so we accidentally left the water on multiple times because the water would turn off around 6:30, and we'd go to the scrub sink to wash our hands, flip the water on, realize it wasn't on, put some soap on our hands, wipe it off with the towel, forget to shut it down. Next morning we'd walk in the OR, it'd be flooded. And so that 4-pronged electrical cord was sitting under 4 inches of water this Sunday morning when it started to go off, and fortunately none of us were electrocuted. But this is the anesthesiologist dumping water off the floor. The OR was ready about half an hour after this incident. I mean, they were just, like I said, I couldn't get over how organized and well run the hospital was. These are the transport folks taking someone out of the church over to the OR. This gentleman theoretically sustained this fracture at the time of the earthquake, distal humerus fracture. We didn't want to treat it in a cast alone. We thought we might be able to open it, clamp it, put a couple of lag screws across it, and then put it into a posterior splint. Unfortunately, what we found out when we got in there was this was at least a 9-month to 1-year-long non-union, malunion with sclerotic edges, and that was not something we were prepared to deal with. We'll show you what happened to him in a little bit. This is that greater tuberosity fracture from a couple days before. The shoulder's reduced and doesn't look so bad. Zama Lasante, again, Friendship and Health. This is the local bar right outside the hospital. They would sell Prestige and rum and Diet Coke. You could walk down, we took a tour through the shanty town that we were working in. This is kind of just the view of the town that we were taking care of, or the people and the community that we were taking care of. This goes down to the water. This is the water supply to the city. I refer to him as collateral damage. He was our tour guide that morning, or that evening, I should say. He's a first-year medical student in Port-au-Prince, wants to do cardiothoracic surgery. I asked him if he was on break without thinking, and realized later, after he told me, that his medical school was in rubble. And so he doesn't know what he's going to do now, but I call him collateral damage. His family was not affected by the earthquake. He had no personal friends or family that were killed in the earthquake. He knew nobody who was injured in the earthquake, but his life is drastically altered now because he doesn't know what to do. This is the generator that supplies all of the water to the hospital. It's about 1980s. They lived in one-bedroom, no-bedroom homes, $100 to $300 shacks, if you will. These houses are meant to last about 1 to 3 years. If you walk in the front door, there's an area to sleep, an area to eat, and typically an area to go to the bathroom, separated by maybe, if they're lucky, a wall. If they have any worldly possessions, they're on the walls. And this is typical of most of the homes in Haiti. And you can see structurally, if there's an earthquake, what would happen if this thing came crumbling down. They didn't have a soccer ball, so they played with a plastic bottle, communal shower. This is an intramedullary nail that was put into a femoral shaft fracture. You can see it's actually not in the femur, but she was reduced, and we just left it. You learn not to criticize, because when you realize what you were dealing with, it was what it was. So this was done by one of the previous teams, but like I said, she was reduced and she looked good, and so we just let her be. This is that gentleman who was from the Dominican who took advantage of the fact that we were there. We called him Bang Bang because he had actually gotten shot. That's how he sustained that distal humerus fracture. He has neurologically intact, and we put a couple screws across his humeral shaft. We'll show you those x-rays in a few days. Again, the transport people working hard. I learned what a wet read meant. This is how we developed the films. They were actually dripping wet. Hence wet read. And so we would capture the films as quickly as we could. They were actually right outside our operating room where they were drying them off, so we'd be able to see what we did to patients several days before. And you can just see the films kind of lined up drying off. Distal femur fracture happened at the time of the earthquake, showed up now 3 weeks after it happened, treated in a soft dressing at an outside facility. Mountains beyond mountains, right? And just what a picturesque moon. Rounds again. This is a code. We walked in one morning. There was an active code happening. She was getting chest rubs by the nursing staff. We actually our general trauma surgeon ended up running the code. There's my orthopedic resident standing there, and I'm taking a picture, so you can see how useful we were. The patient died about 2 hours later. Rice for our meals being sorted out. This is CDR, Central Supply. We would go down there every couple days and try and dig some supplies out. These are our bags of equipment that we brought. Day 9, 1,500 people showed up. It was the first day that I felt uncomfortable. 1,500 people meant patients and their families, accompanied by security. This is the first time I saw security forces on our campus, and it was a little disconcerting. But we were close to going home, and so it made it all better. Another femoral shaft fracture in a patient treated in a soft dressing. This again happened at the time of the earthquake, quite sticky. This is that patient that we were talking about before, the one that took advantage of us. I keep saying he took advantage of us because I think he did. This is what we did to him. I don't think it's going to heal. He's in a long arm cast now, and I don't know what's going to happen to him. Here's that wound we did that Donati closure on. You can see it's just starting to break down. There was a microscope there because we were talking about doing flaps. Not that I would consider doing it myself, but they had microscopes in the operating rooms. I think this is a Toyota. This is how they kept the patients on the bed. 3-year-old, soft tissue injury, reconstruction very difficult. Patient's family and patient herself were tired of going to the operating room, so she bought herself an amputation. This pin's replaced after his fracture that he sustained at the time of the earthquake, kind of showed up for follow-up care, and you notice the pins aren't actually in bone. So we redid his surgery and labeled it because we didn't know when we were going to be getting back to him or who would be getting back to him. This is that young lady who walked on her tibia. This is a few days afterwards. We finally got x-rays. Patient had a PE, needed to be intubated, and sent down to Port-au-Prince. And so this is the commotion that night when we were trying to get her into an ambulance. Burning fires in the background, secondary to the deforestation that's happening in Haiti and still happening in Haiti. Here's that femoral shaft fracture, and the patient was treated in a soft dressing. seems well aligned. The Howie Mandel routine, for those of you who are Howie Mandel fans. Some of our skin grafts took, others did not do so well. This is that church complex. You can see it's starting to empty out, and maybe we're making a difference, I don't know. But it's starting to be a little bit cleaner. This is just scenes of Haiti. You can see the deforestation that's happened to the country. I actually like the door hinges. They're bottoms of a shoe. This is as on our way out the door. Again, we're leaving more work for the teams to follow. It's a skin graft that took about 50%. Another IV pole. Here's those pins that we fixed on that patient with the hand injury. Open amputation, guillotine. We just left it open, granulating in. The second to last day we were there, new anesthesia machines were delivered. 4 new anesthesia machines, state of the art. Absolutely phenomenal. My anesthesiologists were giddy. Our French anesthesiologist, absolutely phenomenal. Turnover time was nothing less than stellar. He would carry patients into the operating room if need be. This is the community that we, again, took care of, or at least were in. And here's that picture of that bar. At night, there would be a DVD player here, and they'd be making plantains and chicken, and there'd be a handful of people out here drinking. On our way back to Port-au-Prince, it looked like business as usual. This is Mirabel on the way back to Port-au-Prince, and it was active. It was Friday morning, and people were out shopping, and it just seemed like there was nothing wrong. And I, to this day, still hadn't seen Port-au-Prince. This is that Aristide complex that we slept in. This is the Children's Hospital of Philadelphia team. They came down a few days before we departed, and they unfortunately were working night shifts, so they slept during the day, except the tents were too hot to sleep in during the day, so they just slept outside. Chickens running around. Again, the Clinton Foundation played an active role in this. They actually helped sponsor Partners in Health, and we just slept outside since there were no tents available that evening. This is the first day I actually got to see Port-au-Prince. I was a bit of a tourist of a bit macabre because you're touring the destruction, but this is what Port-au-Prince looked like. And it now finally started to dawn on me why we were here, because I hadn't seen any of this until now, other than what we saw in the news. This is the White House using pictures of. You can just see the rubble everywhere. No one actually cleaning the city, cleaning the town. This is the church, as we saw earlier. This is this man's house. You can see burning fires everywhere, electrical wires just down. This is part of the university complex, Tent City. This is the nursing school. You probably heard about this. The nursing school collapsed. Classes were going on. The entire second-year nursing school class is actually under this building. They still haven't been dug out, to my understanding. The airport, even at 2 weeks later, as we were leaving, 4 weeks after the earthquake, still very busy. Plane landing, C-130 taking off, and a French plane getting ready to leave. So there was lots going on the tarmac. The tarmac was still the terminal. So we were there for 9 full days. We brought 1,200 pounds of supplies. We did 84 surgical procedures. 76 were primarily earthquake related. We had about 1,000 patient contacts. If you looked at the people we rounded on, the patients we saw in the emergency room. We did implement systems when we were there, things like daily wound rounds and sign your site, because the x-rays weren't marked and patients didn't speak English, so we would try and struggle to do sign your site in the morning on rounds. I have no follow-up on these patients, and that's a bit disconcerting and a bit frustrating. This is just a picture of what you just in the back of your mind, what you think we need help. So in 2 months, there's been about 60,000 procedures done. There's 4,000 new amputees and about 250,000 people estimated dead, and there's probably more that are not counted. And there needs to be a long-term commitment. The entire country of Haiti currently has 20 orthopedic surgeons that are Haitian-based, and there's 2 active fluoroscopy machines. They have 3 machines. One of them is broken, so they have 2 machines that actually work. And then just again, I can't commend the U.S. military enough for their efforts down there in terms of not just keeping the peace, but delivering aid. Thank you.
So thank you very much, Samir. Jim, would you care to join us? I think we've seen utter devastation, and we've seen very noble help delivered under great personal efforts. We've seen private care and what single human beings can do. We've seen U.S. government care delivery. We've seen differences between the two. Was there any interplay between the government and the private play to try to optimize efforts?
Our interaction with the U.S. government was fairly limited. When we got to the airport, they were very generous in terms of helping us organize our SUVs. And as soon as we left the airport, we did not see the U.S. government again until we returned to Port-au-Prince and back at the airport.
So we had an interesting experience because of that one individual I showed, Henri Ford, who was a native Haitian. And he was very instrumental because he would go out during the day and drive around to all the hospitals in the area that he knew. And he would try and figure out who had what resources early on in an effort to sort of match surgeons with equipment, with functional ORs. And we sort of played a role in that because we were able to provide him the infrastructure to do that. Unfortunately, the U.S. government runs in a fairly protocolized fashion, which is putting it mildly, and our ability to interface with organizations that we didn't have a pre-existing arrangement with were very limited. So at times it was frustrating because we knew of the resources that we had and others' resources that we could benefit from through Henri, but we weren't actually able to interface very well with them.
Did you, from the government, have all the supplies that you needed to try to deliver care?
Oh, certainly not. And I think, again, that speaks to the bureaucracy, for lack of a better description, of a U.S. government effort. It's very top-heavy in personnel and decision-making, but when it comes to nuts and bolts on the ground, it was very difficult to change to the conditions that we saw. I mean, this is a response team that's set up to generically respond to a disaster of unknown type. And so our ability to tailor the mission was very limited, I thought, in the early going. And I think, again, it speaks to the ongoing nature of the effort, the fact that every 2 weeks it was changing personnel. Things changed relatively quickly, but from our perspective, maybe not quickly enough.
Thank you all. So with this, we'll have to conclude due to time constraints. I want to thank the speakers very much, and I'm very proud of your work, and there's a lot of work left to be done. So thank you all.